local and state public health practitioners. Since we started our PBRN, we have expanded to a statewide PBRN through a collaboration with our SACHO, our North Carolina Public Health Association. We created an academic practice-based research network work group. At the time, Mr. O'Daniel, he was president, he wanted to figure out a way to better connect academic researchers and public health practitioners interested in advancing the science of public health and the integration of that science to public health settings. And so we have been able to generate greater interest around public health systems and services research. Through this network, we've added other universities, ECU, UNC Greensboro, Asheville, and others. And so now we're working together to continue to build momentum around this research. Next slide, please. So this is the study team for this project, Dr. Wells and myself. And Hai Chung is our informatics and data mining expert. Shirley Richards provides some support for programming. And then we have Matthew, our student, and Ravi is working with us on the data. We also want to recognize our partner at the State Center for Health Statistics, Dr. Whitmire, who's been so helpful in helping us collect the data we need for the research. And then a colleague of mine, Rosemary Summers, who has since retired. She was the health director at Orange County, and she's actually working with our network on some other projects. So we're not letting her stay retired very long. We have to say that we got a great response to our survey, which we used to collect some data. 89% of our health departments completed the survey, and we're also grateful to the Division of Medical Assistance and our WIC program for also helping us with some of the data we needed for the analysis. Next slide, please. So a little bit of background about maternity care coordination and child service coordination. This program was created back in 1987 when North Carolina had the worst infant mortality rate in the country. And I'm happy to say this year we're at our lowest infant mortality rate ever historically in the state. So those of us who work in public health feel that we can take a lot of credit towards those improvements. Up until this year, all pregnant women who enrolled in Medicaid qualified for maternity care coordination. And children who are age 0 to 5 who either had a documented developmental delay or had risk factors for developmental delays also qualified for the Child Service Coordination Program, which is a similar program to maternity care coordination. Our objectives for this study were to understand how the recent cuts to the case management services and restructuring has impacted that program, and whether there are factors, organizational leadership or other contextual factors through the health department or board of health that maybe might moderate these effects. Our study focused on questions that we hope to would clarify the impact. The specific questions related to how the revenue cuts through Medicaid and restructuring of the program affected service provision and outcomes, and also the degree to which the cuts and restructuring affected core capacity for health departments in other areas. So in North Carolina, we're a decentralized state. Much of the funding for public health comes locally through county appropriations, but probably about a third comes through Medicaid. And so many of the staff who work in these programs supported by Medicaid revenues also work in other areas of the health department. And so we wanted to know if they were also impacted. And then how does local health department capacity and adaptive strategies reduce the impact of these cuts and restructuring? And this really is designed to provide us with a better understanding of how financial and structural changes in a program like MCC and CSC impact services, and then are there strategies or adaptations that the health departments can use to modify those impacts. This really has been a natural experiment because no later did we get notice of our funding. There were other impacts, environmental impacts. The maternal outreach worker program was eliminated. This is a paraprofessional program to support the professional services of the maternity care coordinators and child service coordinators. And then more recently, Medicaid has restructured the program to a medical home model so that the Medicaid networks in our state are now lead entities in providing prenatal services and well child services for kids. And they also now have a clear accountability role for the outcomes of the women and kids who are getting Medicaid services. So there's a new partnership between health departments and these Medicaid managed care networks. So we've had to adapt to changing context as well. Next slide.
So we have used, appropriate to the your following agenda, a multi-method study design for this project, and have collected substantial data on North Carolina's 85 local health departments using previously collected data, for instance, from the NACHO survey, data the state signed enough to share with us, for example, on expenditures in different program areas, staffing, and also data we collected through the, actually this is a 2010 local health department survey we fielded last fall, which Dorothy already alluded. In addition, just as of last, we have our final data draw from Tim Whitmire at the State Center for Health Statistics on a simple random sample of 8,000 Medicaid-covered births. And for each of those, it's actually really 16,000 because we have the mom and we have information on the baby. That is Medicaid claims and eligibility data that we're going to be using to understand patterns of service use, both merging those data into the health department file for health department level analyses and merging the health department data and contextual data at the health department level into individual records to understand how health department and contextual factors, as Dorothy noted, affect service use and outcomes for women and for children in the first year of life. On the qualitative side, we had initially planned a case study, a comparative case study, to understand what was supporting effective or relatively more effective care coordination, and then restructure the case study in light of the March 2011 shift to the medical homes model. So Dorothy got out to actually a pilot site and 4 local health departments in a 4-week period last winter to collect baseline data prior to the March initiation of the medical homes model. So those February data speak to what care coordination was like in the prior model and thus are relevant to understanding how the pre-existing system was functioning. And now she has, with various helpers, finished going back to all 4 health departments and asking how the implementation has been rolling out so far. Slide, please. And so we're going to share just a little bit of the data we're beginning to look at from the sample that we got last week. We had a pilot sample we spent several months working with before getting that final draw. And just wanted to share with you, again, these are rough statistics. We're actually going to get another file, the composite matched birth file, about Christmas time that we'll use to merge back in more precise birth date information and then regenerate these numbers. But the first thing we thought we'd start to peek at is the trends of service use and some descriptives to get a sense of how stable has the system been, how stable has the population been before and after the cuts. So just for these few slides we're going to share with you now, what we did was The random sample was structured to include 12 months of birth prior to the October 2009 19% reimbursement cut. That was the initial focus of the study, and then 12 months subsequent to that cut. And the first question we had was, are health departments serving fewer women as they are less well compensated for those services? So what we did here on the x-axis is we just took every mark there, every month is the births that occurred in that month, a little month cohort, if you will, of birth. And this line chart portrays what proportion of the mothers whose deliveries were covered by Medicaid and their infants received maternity care coordination. That's the red line, so it's a little under a third, or child service coordination. And of course, two things jump out at us. One is that a much higher proportion, but by no means the majority, of Medicaid, of women whose deliveries were subsequently covered by Medicaid were receiving maternity care coordination during their pregnancy. And secondly, that a far lower proportion of children received child service coordination, which makes sense because there were, whereas all women enrolled in Medicaid during pregnancy qualified for maternity care coordination, only children, as Dorothy noted, with or at risk of developmental delays qualified for child service coordination. And the second thing that jumps out at us, I'm sure, is there are no trends here, that there was not a trend downward in aggregate overall in North Carolina in the proportions of women and eligible babies, or babies overall, who received care coordination. Next slide, please. So then we thought we'd just look at whether the people who were receiving care coordination got less of it. I mean, this is kind of the supply curve hypothesis. I was sharing this with an economist colleague yesterday who was upset to see this. They're not very profit-driven, apparently, local health departments, because there has been no evident decrease in the number of units of care coordination received by, this is now we're focusing on moms, and we have three lines. The green line on the top is the total number of care coordination units of service, and these are in 15-minute increments received during pregnancy and the first 3 months thereafter. And we just we split it up. The red line is during pregnancy and the blue is after. So again, what we're seeing is that we are not seeing support for our speculation in the fall of 2009. Health departments might be rationing services in response to decreased reimbursement. Next slide, please. Then we're continuing to look at trends, but at the same time, we wanted to begin to get a sense of what characterized the population of women receiving maternity care coordination relative to women enrolled in Medicaid who did not receive maternity care coordination. And we can see here that women who received maternity care coordination also received more OB visits. And we have here the red line is in the 10 months prior to delivery, and the blue line is the 3 months after. So we have an immediate indication that patterns of service utilization differ from maternity care coordination and non-maternity care coordination enrolled women. This, of course, begs the question as to what's leading to what here, whether women who are just more predisposed to service use are also enrolling in maternity care coordination, or whether maternity care coordination is having its intended effect and increasing engagement with preventive services. Next slide, please. We'd also heard qualitatively, we spoke to a lot of people when we started this project and asked, what was the theory of change of maternity and child service coordination back when both were founded? What are they supposed to be achieving, and what might affect that? And one of the things we heard is that maternity care coordinators continue to provide support for women after their birth, and that they sought to facilitate use of family planning so that they would be able to plan birth spacing thereafter. And so we looked here descriptively at the proportion of non-maternity care coordination enrollees versus maternity care coordination participants who were receiving family planning. The red line on the top is the first 3 months after birth, and we're just trying to get a sense of what the window of opportunity was for post-delivery family planning. So the blue line is the second 3 months after delivery, and clearly the key window of opportunity is on those first 3 months, give us the higher red line. But also we're seeing notable difference between the proportions, those women enrolled in maternity care coordination versus those who are not. Next slide, please. Sadly, we'd like to say, well, if they're using more preventive care, then they'll be using less reactive care, but that is not the case, at least descriptively in aggregate. We measured emergent care in 2 ways. One was total emergency department number of visits. The red lines represent the total number of emergency department visits during pregnancy. Then the blue line, which is intermingled with the others there, is total number of emergency department visits in the 3 months after delivery. And then we also looked at a subset of those considered to be ambulatory care sensitive. And there is, again, a notable difference with women enrolled in maternity care coordination more likely to visit an emergency department during pregnancy and I'm going to say after as well, although it's just they're lower numbers. And it also just jumped out at us qualitatively that visiting an emergency department is not a rare event for women in this sample as a whole, either those in maternity care coordination or those who are not. It's averaging close to a visit per woman during pregnancy. Next slide, please.
So one of the things that we hope to get a sense of from these case studies was related to the transition. It was a pretty rapid transition from a model whereby pregnant women who were eligible for Medicaid were eligible to receive MCC to a model where there was a required screening done by the prenatal care provider. So now we are in a system where the practitioners or the providers need to provide an initial screen in order to qualify the woman for the service. The screen is then forwarded to the care management team, and the women with the highest medical risk, though there are a number of women screening in for psychosocial reasons as well, are enrolled in this case management component. It's now capitated. It's a per member per month reimbursement to the health department, whereas it used to be fee-based, fee-for-service. And the services provided are tailored much more to the individual needs of the pregnant woman. One of the benefits of the program is that the public health staff who are providing the care management services are now linked very closely to the prenatal care provider offices. And in many counties, the local health department is also providing prenatal care in addition to case management. In some counties, this was not a big challenge because they'd worked closely with practices before, but in some of the counties, this is a whole new way of delivering services. When we went out to the sites, we found that most of them were using the new information system, an electronic system of data entry, which seems to be much more preferred to the paper data entry medical record that they were using formerly. And they are being held accountable for outcomes. They're clinical and cost outcomes. And so the health departments are now under contract basically with these community care networks, these Medicaid matched care networks, to deliver these care management services, and they will have to document that they are achieving the expected results. So there is accountability, there's cost savings, and there's also an emphasis on providing the services to those with the greatest needs. Next slide, please. Some of the concerns that were expressed relate to the risk criteria. It seems that some of the providers are figuring out how to get women the services even if they're not qualifying based on the screens. They have another category. We heard that teen moms in particular may not be screening in using the standard criteria, but they're still being referred for the care management services just because of their age and the needed support that they require. We are finding that the women who are receiving the service were very similar to the women who were receiving the service before. And though not every pregnant woman needed the care coordination in the former program, they're generally still a high-need group. If for no other reason, their limited resources, their eligibility for Medicaid tends to correlate with other social needs that they may have. We have noted the health department providers, the case managers, are identifying significant differences in the model. And while they've received state training and they've been asked to do transition plans and they've been evaluated on those plans, there still seem to be staff who are uncertain about the program expectations, their roles, how they're evaluated, and it's unclear that there's been true fidelity and implementation across the various networks. We have 14 networks in North Carolina, and they're all very grassroots run, and so how this is working is varying from network to network. Next slide, please.
So, in essence, our original study hypothesized that health department resources and strategies would moderate the effects of funding cuts on service use and outcomes. So, but if the health departments have been effectively absorbing the cuts without modifying service provision, which is what our data so far, both survey data and the data we've just shared with you, suggest, then we'll shift analytic strategies and focus instead on how the health department what health department resources and strategies affect service engagement and outcomes per se, as opposed to the effects of a change. In addition, we've now collected all of the case study data and are almost done correcting the transcripts, and so we're going to begin to code those transcripts and other documents and prepare a report for participants and understand the differing implementation of the medical homes model. Next slide, please. In addition, we wanted just to note that we've been combining forces with Penn State principal investigator as well as an economist here at UNC to use some of the same data, in particular the Medicaid claims and billing claims and eligibility data, to re-examine the evidence base behind care coordination. And Marisa Domino has also shared a Robert Wood Johnson methodological administrative supplement to apply advanced econometric techniques to reduce the effects of systematic differences between care coordination recipients and non-recipients on our estimation of the focal effects, the causal effects of the programs themselves. Next slide, please. So now I think we're ready, not too many minutes after we were scheduled to end, for questions or thoughts from others.
Fantastic. Thank you so much, Rebecca and Dorothy. This is very, very interesting work. So do we have some questions from the field? I would say at this stage, if you have a question, go ahead and just jump in on the telephone. Unfortunately, we're not able. We're having a little bit of technical difficulty. We're not able to navigate the kind of the online raising of hands, et cetera. So, so just jump right in and vocalize if you've got a question to ask. Maybe I'll start it up. I know one question that comes to mind for me as I hear this work, and as you said, Rebecca, it appears that that health departments are absorbing the effects of this payment change and continuing to be able to deliver a consistent level of service despite the reimbursement change. That to me raises the possibility of perhaps some or the question of whether some unintended consequences, or how are health departments absorbing those changes? Are they cutting back in other areas of service in order to maintain this level, or are they really finding more efficient ways of delivering the same level of care? So is there some cross-subsidization going on? Are they robbing another program to subsidize this activity, or are they simply finding more efficient ways to do the same kinds of things? Do you have some thoughts about that, or any ways of looking at that?
Because that's exactly what we asked them in the fall of 2010. Was we asked, have you been cutting into other programs? How are you making up for this? And the health directors did not report decreasing funding to other programs. So I'm not sure how they've been. I mean, anecdotally, we have heard reports of just moving funds around, but the survey data did not support our speculation that, and part of what health directors were telling us in the fall of 2009 was that they were going to have to make significant cuts. They're going to be losing core capacity in other areas. But at the time, the reimbursement cut was anticipated to be larger, 38% instead of 19%.
Right.
A few of other thoughts about that. Yeah.
Well, hi, I'm sorry, this is Elaine O'Keefe in Connecticut with the Connecticut PBRN. I was going to raise the same question as that you did, Glenn. As you know, well, some of you know, in Connecticut, we're still finishing up a quick strike study where we looked at the impact of cuts in subsidy funding to local health departments on their capacity to continue to provide services. And we're still finishing up part of that and trying to figure out, we're not seeing a lot of impact in terms of cutting services. We're seeing what is remarkable resiliency in being able to somehow absorb. But we're not sure that we're asking all of the right questions and really looking. It just doesn't. It seems counterintuitive that it would be this way. So I think it's a really interesting question.
Yeah,
what is going on?
We're a little hesitant as well to publish something saying go ahead and cut health department funding.
Exactly. Yes.
Well, we even explored the nature of the visits to see if maybe there were fewer face-to-face visits and more phone calls, because I think we speculated that maybe there might be some efficiencies gained by not making as many home visits or seeing people in clinics. That didn't seem to be the case either, that the actual care coordinators did not seem to change their service delivery activities to any large degree. My perception is that, in many areas of public health, people are just working longer and harder to get the job done with fewer resources, and I think
is that sustainable? If that's the answer.
This is Shoshana Sofair, and I'd like to come in on this conversation because I'm on the board of the Public Health Solutions in New York City, and I have watched them over the last several years absorb and absorb and absorb cutbacks, and they did it. They got to the point where they became phenomenally efficient, and they dealt with all kinds of issues in terms of staff turnover and other kinds of issues that were getting in their way. But then they hit a wall.
Yeah.
And they couldn't do it anymore, and they had to start, closing down services. They had to start laying off people. And so I think that this is an issue of, when is it really going to hit bone? Mm-hmm. And the other question, however, that I would ask is, I'm wondering whether there's a speed up going on where people are not just working longer and harder, but they're spending less time with each of their patients. I mean, this is what physicians are doing in the medical care system right now. They're not spending 15 minutes, they're spending 10 minutes, and then they're not spending 10, they're spending 8. And that kind of speed up can be going on, and I'm wondering whether or not we're missing out by not also tracking the client experience of getting the care, and whether or not that is really diminishing.
Well, we actually built that into our case study design in that we plan to speak with pregnant women and the return visit at 2 sites. But then the health directors told us not to come back 3 months later, but instead to come back 7 months later or 8 months later because it was taking that long for the dust to settle on the medical homes implementation, by which point we didn't have the comparison anymore. We couldn't ask a woman what happened to your care coordination during this pregnancy after the cut. But we did, however, speak to about 15 mothers at 2 sites about their experience of care coordination.
Hi, this is Barbara Pizzocani from Portland, and I was wondering, you mentioned WIC, that you looked at WIC services or WIC data early in the presentation, but I wondered if you saw any effects on WIC. Potentially, some of this care coordination could have gotten, or at least the way it's structured here, it could have an effect whereby the WIC staff, bears or absorbs some of this burden in terms of triaging women and referring them on. I just wondered if you looked at that at all.
What we're currently planning to use, in fact, I just got an email from Tim Whitmire this morning. He's just sending over the WIC data today, and we're planning to construct a variable of WIC enrollment after enrollment in maternity care coordination, because one of the things we've discovered qualitatively is that people flow both ways. They get into WIC through maternity care coordination, and they get into maternity care coordination through WIC. And since our focus is on the maternity care coordination, we wanted to see if women in getting that kind of coordination were more likely to then receive WIC services and maybe engage for longer in those services. So that's what we're planning to use.
Yeah, it'll be interesting. Thanks.
This is Susan Zahner. I had a question. I think if this sort of thing would happen in Wisconsin, and the health department, I would see that, no change before and after. I would look to see to what extent the local governments were filling in dollars, because most of our local health department funding comes from local property taxes. And so I would look for whether, because at the local level they valued the health department or valued these kinds of services, that they actually filled in, and so the overall resources stayed the same, though the funding coming from one source declined and local sources increased. Could you look at that at all?
Well, we asked that. Yeah, we asked that in the survey as well. And what I recall is that so we asked, one thing we asked was how much of a priority is maternal and child health for various stakeholders, your Board of Health, your county commissioners, for the general public. Then separately we asked, have you asked for money to make up for these cuts? And very few, and then we asked, and if so, how much did you get? And very few local health directors at that point had approached their county commissioners for funding to make up for the cuts.
This is Scott Frank in Cleveland. I'm wondering whether there are any outcomes other than the provision of care that you would have to look at that might comment on whether there's any change in the effectiveness of care rather than whether care is being offered, which may get at the comprehensiveness of visits or may get at the issue of efficiencies that have been taken that may decrease effectiveness.
We're thinking of the emergency department use and ambulatory care sensitive as beginning on that continuum of, those are service use measures, but there are, can be seen as the results of preventive services not working. But in addition, we have constructed measures of health outcomes. So we have the low birth weight babies, we're getting those from the birth certificate, preterm birth, and we're working on, but I'm not sure if we'll pull this off, we're trying to the maternal weight gain during pregnancy, because that's a major, an increasing public health concern related to, for instance, gestational diabetes.
One of the things that you may have already looked at, but also may be worthwhile, is actually looking at the infant emergency department visits.
Yeah, we've constructed those measures.
What's that?
We've constructed them as just emergency department and then ambulatory care sensitive, but they seem to be, for infants, they seem to be the same thing. Hmm. Yeah, we're going to have a look at that as well.
Good.
Fantastic. Do we have any questions? Go ahead.
You make the point that the risk scale is really based on medical risk. Do you have any sense that if psychosocial risk or behavioral risk was considered, that these outcomes might be different?
I think there are a number of psychosocial risk factors, but it seems like the emphasis is to address like preterm birth issues. So the you know, some of the strategies are more medical in nature, but they still include issues of, you know, violence, interpersonal violence, substance abuse. Most of the women are screening in for tobacco use, which is included there. And so I wouldn't be surprised if there was kind of a tweaking of the screening criteria going forward, because so many women are screening in. And we do have social workers and nurses who are providing the care management services. So the psychosocial issues are still being addressed, but they're not uniquely separate from some of the medical risk factors that are also qualifying women. I think they're highly correlated.
Great questions. Well, I hope you all join me again in thanking our colleagues from North Carolina PBRN and thanking Rebecca and Dorothy for spending this time taking us on a tour of some very interesting research in progress that they have underway in North Carolina. At this stage, we're at the time now where we want to transition on to the next item on our agenda. But I actually think that this conversation that we're teeing up for next dovetails quite nicely with this earlier discussion around the research approaches and the findings that are coming out of North Carolina's study. But for this next segment on our call, we are very, very fortunate to have an expert in mixed method research methodology who has been willing to drop in on our call this month and spend a little bit of time with us in some further dialogue about strategies for mixed method research. And it's a great opportunity for us to pick the brain of a real leader in health services and health policy research. and that is Dr. Shoshana Safair, who we've actually already heard from earlier on the call today. Dr. Safair is well known to those of us who have worked in the health services, research, and health policy community. Well known for her expertise in mixed method research strategies. She is currently the Robert P. Luciano Professor of Healthcare Policy in the School of Public Affairs at Baruch College in New York City. And she's also held faculty positions at George Washington University in D.C. and at UCLA School of Public Health in California. And many of you know and participated in the webinar that she produced in conjunction with Academy Health last week on this very topic of mixed method research strategies and kind of advances in cutting-edge techniques in combining the strengths of quantitative and qualitative research strategies. And so kind of as a follow-up to that excellent webinar that she put together with Academy Health, she's agreed to spend a little bit of time with us today on the phone and gives us a chance to ask some further questions of her, and hopefully will stimulate some further thoughts on your part about research strategies that you can be using within your networks. So first, let me say thank you again, Shoshana, for agreeing to spend some time with us today.
Perfectly welcome. Those letters at the end of my name do mean a lot to me, you know, DRPH.
Absolutely.
That's where I come from. So, Glenn, are we going to open up for questions? Because you had also sent some very stimulating ones along, but I'd love to first begin to see if any of the people who are on the call have anything they'd like to ask me.
That sounds great. Yeah, why don't we do that? Let's open it up first. We did receive some questions in advance from email from several of our folks, which I passed along to Shoshana. But yeah, let's open it up and see if there's some questions. Maybe some that were stimulated by hearing about North Carolina's research in progress. Well, hearing none. So again, feel free, folks, to jump in on the conversation as some questions emerge for you. One question I know that we received via email, kind of a general question that I know many of our networks are faced with in pursuing these mixed methods approaches, is the issue of how to make decisions around sampling and case selection on the qualitative side of their projects, particularly you know, when they have a mixed method research project and there are quantitative components and then qualitative components, like the study we just heard from in North Carolina, where you've got good quantitative components coming out of a survey of the local health departments, and then quantitative data coming from claims data that allow you to look at issues of service use. And then this research team was faced with a decision about wanting to do qualitative research, selecting health departments to do qualitative research, and then even selecting some individual patients to do some patient interviewing with. How do you make those decisions about how to sample or how to select cases, and what kinds of issues are you considering when you're implementing that or designing that part of your study? Do you have some thoughts or comments, Shoshana, on those issues?
I really do, and one of my views is that, first of all, to me, sampling is one of the critical issues in research design, period, that often doesn't get enough attention. And in my purely qualitative work, sampling has been so, in many ways, determinative of both the quality and rigor of the work and my findings, that it always reinforces for me the importance that needs to be attached to those issues. Now, I think on the webinar I presented sort of different relationships between the quantitative and qualitative components of projects, but there is one model that I have, one thing that a lot of people do is that they actually use quantitative data as a basis for doing qualitative sampling. And I'm going to go way back to my own doctoral dissertation where I did that, but not on the basis of, actually this wasn't numerical data, it was I got expert opinions about the performance of, at that point, community health planning agencies in the area in which I was studying, which was how well they did on the implementation of their plans. And I had access to and used a large network of people in the western United States who told me basically who they thought the top 3 in the western United States were and who they thought the bottom 3 in the western United States were. What was very interesting was that there was much greater reliability and consistency in the responses on the lowest performers than there was on the highest performers, but I nevertheless was able to pick basically 6 agencies, 3 in the high-performing group and 3 in the low-performing group. And so that, again, that process is based on also the nature of my research question, which was to try to identify what differentiates agencies in terms of their effectiveness. And since I was doing a mixed method study, I needed to be able to limit the number of cases that I was looking at. So this is how I limited the number of cases. Now, in another project that I'm hoping to be working on, and it has to do with actually infant mortality, actually, neonatal mortality of very low birth weight babies, we are going to be selecting hospitals to look at in depth on a qualitative way by analyses of their risk-adjusted, very low birth weight mortality rate in their NICUs. Okay, so I just want to say that one of the joys of mixed methods is that you sometimes can use the quantitative data to develop your qualitative sampling. But the other that Glenn also mentioned in his email was more of a theory-based or almost a hypothesis-driven way of doing sampling, which is more what I was doing in my doctoral dissertation, where it was not a hypothesis, it was more my research question and my underlying theory that there would be variation on this. I wanted to be able to get variation, in this case, on what one would consider the dependent variable in my study, okay, on performance. The other thing that people often do is look for variation in the independent variables that they're thinking are very important in their study. So I guess to me, sampling is where thinking, this is going to sound funny, thinking is so profoundly critical. If you have not thought through your study, your sampling will be terrible. I can just tell you that. You've got to pay a lot of attention to it. And, it's not just a matter of, getting diversity. You have to be very, very specific about it. So, for example, what I'm concerned about, sorry, but we have another phone in this room, which my husband has just picked up. For example, let me use focus group sampling as an example. When I do focus groups, the sampling is probably half of the game. The specifics of what kind of people I want in those groups. It's absolutely critical. And it, again, depends on your research question. So let me use as an example a study that I did of how patients respond to the care that they get in hospitals from nurses. Okay, so we, first of all, picked 3 cities where we were going to do this work. And we picked them on 2 criteria. We picked them, one, on the criteria of it was feasible for us to go there from a budgetary perspective, and this didn't have so much to do with travel costs as how much it costs to actually run focus groups in those communities. So I never run focus groups in New York City because it's just too darn expensive, even though I wouldn't have to travel to get there. But the more important criterion was that we picked places where we could get the racial and ethnic mix that we wanted to get in these groups. Because, and this is, I would have to say, a bias on my part. I believe that it is very important in these situations to get a really good racial and ethnic mix, and to get also a really good mix in the work I do in terms of education level, which of course then will correlate highly to income level as well. So we give, we set up a sampling plan that deals with age, with gender, with race ethnicity, with education level, and we actually specify the proportions of people that we want. And by doing so, we know where the variations lie and where they don't. And then the other issue that you get is, do you want to stratify your focus groups so that some of them, and this is a very common thing that I do, are, for example, only people with relatively low education levels. The reason that's important is, again, because the things that I study, which have to do with, for example, how people can understand healthcare quality measures. If I don't have some low literacy, low education level people in there, I'm not going to really be getting a good idea of the whole community. And the other thing is that there's a problem in the dynamic that sometimes if you have a mixed group, the low-income people will feel intimidated and be quiet, and even the most skilled focus group leader cannot get them to talk. Now, this is by no means uniform. I have had some unbelievably smart, low education people who really make fabulous contributions to groups. But this is where you really have to, this is a business of being precise. This isn't general and vague. This is where you really have to be precise. So the other issue is how do you identify key informants? So you're going to do a case study. You're going to go to a health department. How do you pick who you talk to? How do you pick which patients you're going to talk to? And there are so many approaches there. The fundamental approach for interviews is we call them key informant interviews for a reason. They have information on the issues that we care about. So the primary criterion that you're going to be using is who are the people with the information on the issues that we want to talk about. I'm going to go back to my doctoral dissertation again, where I was lunatic enough and I guess young and strong enough that I interviewed probably in the neighborhood of 15 to 20 people at each of my sites. And I actually created this matrix of what were the topics I wanted to cover, and I had a liaison at each agency that said, okay, who are the people that know about these topics? And I created these matrices, and that's how I actually selected my sample. So again, not off the top of your head, very precise, very systematic, in order to be able to really get the information that you need. So another issue that comes up is, okay, is there ever a role for actual random sampling within qualitative? The answer is yes. So if I was going to be choosing
we've got a little bit of interception, so it might be helpful if folks could mute their phones when, unless you want to ask a question.
I can't talk over this.
Oh, there we go.
Okay, thank you. Okay, I lost my place. Okay, so I was talking about actual random sampling. You might get a inclusion criteria that characterize the kind of patients you would want to talk to, and then use the same kind of sampling that you would be using if you were doing actually select people at random. The critical thing there is that I think the harder question in that context is, how many people do I interview? How many focus groups do I have? And there's this concept that floats around qualitative research, which is called saturation. And I talked about it a little bit on the webinar. Saturation is a concept that I am quite frankly, uncertain about, because I don't think there's been actually any really good research done on what do we mean by saturation and how can you tell when you have achieved saturation. And in addition to that, there are feasibility issues that often trump saturation completely, where you only have enough resources or only have enough time to do X number of groups or X number of interviews, or for that matter, X number of surveys. And you really have to be able to say, this is my upper limit, then how do I get within that number the full range that I hope to get of perspectives on this issue? And to me, those full ranges are very important. I'm going to stop now and see whether people have any questions in response to what I said or other questions.
Wonderful. Thank you, Shoshana. I know another question that we received via email in advance that I think would be interesting to get your perspective on relates to kind of the different kind of modalities of data collection, particularly on the qualitative side. Particularly in the current environment of looking for ways to do research more efficiently and looking for ways of implementing studies with limited resources. In the area of doing interviews is often this tension between do we need to do in-person interviews, or will it suffice to do these interviews via the phone or via some other technology? And then also,
let me just respond to that. I think that my own view is that myself personally, I enjoy doing both kinds of interviews. And I feel very comfortable doing both kinds of interviews. I think that telephone interviews are perfectly fine, except in certain kinds of relatively rare situations. I think you have to have an in-person interview when you're dealing with a situation which is either politically very charged or emotionally very charged. And that will have to do with what the questions are that you're asking and who are the people that you're asking them of. So for me, if I'm dealing with highly vulnerable populations, there's no other way for me but to do it in person, okay? Because I think you need to be able to provide an awful lot of safety. And I don't necessarily think that having a phone conversation provides safety unless, and people have talked about this, the person feels more comfortable talking about a highly sensitive topic when they can't see you, when it is more anonymous looking. But the other kind of politically sensitive area is when you're dealing actually with people who are in power or who are in the middle of a very controversial situation. And in those cases, if you do a telephone interview, you may hit a lot of silence just because people are so nervous about what you're asking them about. And so even the most experienced person may not be able to draw somebody out on the phone and may have to do it in person. But the other thing that I have recommended to people is if you're doing a study that's more longitudinal and you're going to be talking to people at multiple times, I've done this when I've evaluated projects, you do the first interview with somebody in person, but after that you can really go into the telephone and method and do that very easily. Now, the other skill set that I have happened to acquire in my life is that I happen to type very fast. Okay, so one of the things that I like about telephone interviews is that I can get a close to verbatim transcription. I'm pretty experienced, so I can get a close to verbatim transcription on the computer while I'm doing the interview. It gets transcribed anyway, but I can do it right there. And what that saves is that very expensive and time-consuming step of actually getting a verbatim transcription. You don't always need an absolutely verbatim transcription, and unless you've got a very good transcription service and don't take some care in how you present the material to them, you can get a transcript that's got lots of holes in it, and it's very frustrating. So I would encourage you not to avoid doing telephone interviews except in these sort of special circumstances. And I think also the other issue about cost was transcriptions, and do you have to do full transcriptions? I've done this a lot of different ways. I've done full transcriptions. I've also had the person who does the interview listen to the tape and summarize it. Now, part of it depends on how many interviews you're doing and how much in-depth coding you're going to be doing on those interviews or on those focus groups. Ideally, you have the full transcript if you're doing a full set of coding, but in some ways, if you're doing a half a dozen interviews and that is all you're doing, I'm sorry, I don't think you really need to do coding. I think that's sort of like going a little bit over the top. I have, in many cases, in that sort of circumstances, actually created Excel spreadsheets in which I have the rows might be the informants and the columns might be topics that I'm interested in, or even the questions from my interview protocol, and I will pop in text into the Excel spreadsheet and then use that spreadsheet to help me actually analyze the data. Because, you know, however, if you're doing 25 interviews, you cross the line. You're going to have to do coding. You're never going to be able to manage those interviews in something like an Excel spreadsheet. So that's where you really have to, you know, a lot of this has to do with the scope. Okay? Other questions?
Excellent. Thank you very much. So just so folks know on the phone, what I did, I went ahead and muted folks' lines. We muted the lines because we had a lot of background noise. So if you've got a question, if I could ask you to use your little hand-raising icon. If you hit that hand-raising icon, I can see that you have a question, and I will unmute your line so that we don't have quite so much background noise. So so please go ahead and do that. Press that little hand button on the screen. That way, I'll know that to unmute your line and you can ask a question.
You know, I'm not seeing it. Just so you know, I'm not seeing a hand-raising button. All I'm seeing is Ann Kelly's desktop.
Okay, well, let's see.
Why don't you just, for a moment, put everybody off mute and see if we get any questions.
All right, we'll do that. And while we're doing that, I know, Shoshana, this another topic that you have thought a lot about and obviously have a lot of experience with is publishing publishing findings from mixed method studies, especially, you know, qualitative component studies, which, you know, there can be, I'm sure many of us experience some bias in some of our journals against qualitative methods and presenting qualitative data. So do you have some tricks that you can offer us around getting this kind of research published?
Well, I think that just as we have had to in health services research really push on the editors and the editorial boards to let this happen, I think the same thing is going to have to happen in public health. So I think somebody is going to have to beard the line of the AJPH in its den and say, okay, you know, if you can publish Fabulous History by Elizabeth C., you can publish qualitative methods too. You know, history is actually one of the disciplinary roots of qualitative research, and I think we really have to go and, in groups, sort of go after people who are resisting this idea. That said, the other issue that people have to grapple with in order to publish qualitative research is how to be concise in the presentation of qualitative research findings, and also how to make your methodology sufficiently transparent so that people will have faith in what you're doing. And those are two things which, if you don't do those things, you're not going to get past the review process. Third thing that I would suggest people do is also, when you submit a qualitative paper, send the editor names of people who you think have the skill set to review the paper vis-a-vis the methods. Because in many cases, the editors don't know who these people are. They don't have people on their lists who do have a rigorous sense of qualitative research, and we need to sort of be able to promote those people to the editors so that they will know what's going on. Now, that being said, I think it's very important to not try to turn your qualitative research into quantitative research. I get pushed a lot to just, why don't you give us a table with the counts of how many people said what when? This is an absolutely classic response. And I will say, no, I won't do that. And I give a hard reason for doing it, which is I say, if I give you a table, you're going to think that I used a representative sample, and I didn't. You're going to think that this is generalizable to the entire universe, and it isn't. So I don't want to essentially not tell the truth about the method that I used. So that usually gets them. I mean, they usually can't, they haven't been able to come up with a comeback on that one yet. So let's stop for a minute here, and I don't know who is beeping away like mad, but somebody is. Any
Sorry about that. Yeah, so
hilarious.
Everybody's unmuted now, obviously, so if you've got a question for Shoshana, please jump right in.
I have a question. This is Justine Hyde. I'm so sorry to join late and just by phone, but I got out of another meeting late. My question for you is linked to this conversation about the analysis strategy for qualitative data. And, you know, clearly if you're reporting on 5 interviews, this isn't an issue, but I'm wondering if you set some parameters ahead of time in your analysis regarding what constitutes a theme that's reportable. So do you, for example, if you have 20 interviews, do you set a priori or in advance, I will report on a theme if the majority or if 50%, it's a major theme if at least 50% of my respondents, communicate this to me?
I don't do that. And part of the reason I don't do that is because qualitative research is inherently about hearing voices that are not otherwise heard. So that somebody, a single person or 2 or 3 people could say something, and it's a powerful something, it's a meaningful something, it's a substantive something, and to me that's just as important as the stuff that 16 people out of 20 are saying. So to me it has more to do with almost the valence on the theme rather than the number. Sometimes that has to do with the intensity, and one of the things that happens is that people don't just say things, they say things in a kind of a very highly intense way or as a sort of a throwaway. And those are they have 2 very different valences. Is that subjective? You betcha. But that's part of what this is about. I think, again, qualitative methods involve the use of the researcher as an analyst, as an interpreter, as a person who is making judgments, okay? And you must never, again, lie about that. That's the truth of what it is. So I've never done that. But I have to tell you something else. I've done a lot of qualitative research with other people, and I can't remember a time when in doing that I've had an argument with my fellow colleagues about, no, that isn't a theme. Not enough people said that. Or that isn't meaningful enough. It appears in my experience that the themes really do rise to the surface.
I guess my question, I'm an anthropologist, so I've done a lot of qualitative work, and where I get some pushback often is in a review, where people ask, well, what does many or some mean? Many of the respondents, communicate this or reported this. This is the theme that most communicated.
This is again where you really have to say we're not counting here, and we're using these words that are approximate a proportion, okay? If you say almost all, that means almost all. If they're asking you for a number, you have to push right back and say we believe that it's inappropriate to use numbers in reporting on qualitative research. Because some people may have, for example, what are you going to count? Are you going to count the number of times that something was said or how many people said it? Because it could have been said 20 times, but 10 of those times could have been with one person. How do you count that? So I think we've got to, in a sense, stand up for ourselves and say there are sort of epistemological limits to what we do, and if we don't acknowledge those realities of what we do, we will essentially be misleading people, and we don't want to mislead people.
Okay, thank you very much.
You're welcome.
Great question, Justine. Other questions that we have? I know we're running a little short on time, but we have a few some other questions for Shoshana.
So, Glenn, you asked a question about how do you make this rigorous?
Yes.
Okay. Well, one thing I want to suggest, and I will send this citation to you. Kelly Devers, who's one of my partners in Mixed Methods Crime, has written an extraordinarily good article on how to add rigor to qualitative research, and I would definitely recommend that people take a look at that. But I actually do believe that, my goal in life is not just to do mixed methods research, it's to do rigorous mixed methods research. And I think there's a couple of issues here. One of the issues is that in and of itself, mixed methods can add to rigor because they give you the opportunity to triangulate methods or triangulate informants or do that kind of thing. But speaking just on the qualitative side, for example, when you do coding, you need to do inter-coder reliability testing so that you really know that your coders are using the codes in the way that was intended and that there's some reliability there. And so there's actually very formal processes that you can do of having two people code the same transcripts, and then some of the software will permit you to actually compare the coding and see where the differences are. And then the next step is for the research team, including the coders and the sort of team leaders, to sit down and go through, okay, it's almost like what we call a cognitive test in survey research. What was the cognitive process that you went through in making the decision that that code belonged here? And what that will typically result in is a recognition that we need to either specify another code, define the existing codes better, or train the coders better. And so that's a very powerful way to add rigor. Michael Quinn Patton has a wonderful idea. He's a program evaluator and a terrific researcher. And he believes that what we need to do is to actually look for the data that would disconfirm our hypothesis, okay? Look for the data that disconfirms our hypothesis. My own definition of a scientist is that it's somebody who's willing to be proven wrong. And so if you're willing to be proven wrong, you should be willing to go out and say, where can I get the opposite perspective? Where can I get somebody to tell me something different? What question do I ask to make sure I'm not missing that? And that's a kind of a discipline. And to me, rigor is really about that kind of personal discipline. And one last thought about that is this is hard work to do by yourself. And I always think that people need small teams in order to be able to essentially keep each other honest and to sort of debrief and try out different ideas.
Fantastic. So true.
And this is true of all research. I mean, the dissertation research is horrible because you have to do it all by yourself.
Yeah, and again, that's part of the concept of having a PBRN research network and having colleagues that you can do this work with. So perhaps the PBRN structure is particularly well suited for this kind of a team-based approach to mixed method research.
We actually have a faculty member who describes herself as an open-minded skeptic. And what she says is that that's the kind of person that you need to review your papers or review your instruments or review your sampling strategy. Somebody who's open, but who's going to retain a kind of a critical, skeptical point of view, so that you're pushed a little bit.
Absolutely. Fantastic. Well, Shoshana, thank you so much for spending this time with us today. I know it's been very, very useful for us and for our colleagues in the public health PBRNs. We really have a lot of studies underway through the networks that are using mixed methods, particularly the Research Implementation Awards, the RIAs, that are like the one that we heard from North Carolina about. I think virtually all of our RIA studies are mixed method approaches, and so you've really given us some great insight and ideas about how to better integrate and utilize the components.
Let me mention a couple of things. I'm going to be doing a panel on mixed methods at the Academy Health Annual Research Meeting in Orlando in June, and I'm going to be moderating that panel, and I am looking for good papers to present at that panel. So if any of your members want to present, and it would be papers on the mixed methods methodology, not so much on your findings, that I would be looking for papers on. And then I also want to make sure that folks know that we're doing 2 more of these webinars. The first in January will cover research design and data collection, and the second one in February will cover analysis and all of these dissemination issues.
Fantastic. We'll definitely put that on our list and make sure that people are aware of these great opportunities.
Okay. Bye.
Fantastic. Thank you so much. Wonderful. Well, thank you all. We do have a few more items on the agenda, and we had planned to run a little bit longer today, to actually run for another half an hour, so that we can cover some new information about a late-breaking funding opportunity. But just as we're wrapping up on this topic, again, Shoshana came to us as part of our collaboration with Academy Health, which Academy Health, as you all know, makes available a number of different kinds of technical assistance resources to our public health PBRN program. And so I wanted to remind folks that we also have, through this collaboration with Academy Health, we have access to a wonderful series of webinars on various research methodological topics. And we change up that menu of online webinars every quarter. So we've recently lined up a new quarter of webinars that all of our colleagues in the public health PBRNs have access to. So I wanted to make sure that you all have that. We did send out a special email with the listing of this quarter's webinars and how to access them. Normally, these webinars you can only access them with a fee, a fairly hefty fee to view them. But again, by virtue of your participation in the PBRN program, you and all of your colleagues in the networks, any students you may have involved in the network, you can pass this along and make them available to them. The webinars this quarter, we've got a couple webinars, again, furthering on the topic of analysis of social networks and network analysis methods, a webinar on dissemination issues, a webinar on innovations in designing surveys, and again, the webinars the upcoming webinars that Shoshana mentioned around mixed methods. And then we had a great webinar just yesterday on issues around conducting natural experiments and on public health topics. So those are all available to you and to your colleagues in networks for free. So, and if you have any trouble or questions on how to access them, feel free to give us a call or shoot us an email. So with that, let me see where we are on our agenda. We had just a couple of brief items and reminders about just administrative issues in the program. Again, if you've got projects that are coming up on your annual reports or your final reports for projects that are funded through the RWJ Public Health PBRN program, Just a reminder of your reporting deadlines. Make sure to send us a copy of your any reports or your products that you're generating from the research, because we love to see those, and we love to help you as we can with dissemination of those activities. Speaking of dissemination, there are two important conferences that are coming up for us, and the deadline for abstract submissions around those conferences are coming up as well, so I want to reiterate those. The big Keeneland Conference that comes up in April here in Kentucky. Abstracts for the Keeneland Conference are due on January 9th, so that's right after the holidays. And so I know really lots of the research activities that you all have going through your networks are going to be relevant to this conference, and this is a great place to present your findings to like-minded people who are interested in PHSSR, interested in public health practice and the research intersection. So if you've got some studies with findings coming out, think about putting together an abstract for the Keeneland Conference with a deadline of January 9. The other big conference for us in PHSSR is the Academy Health Annual Research Meeting that Shoshana mentioned, be held down in Orlando this year in June. We also have the special interest group meeting held in conjunction with that, the interest group dedicated to public health systems and services research. The abstracts for the main Academy Health meeting are due January 12th, just 3 days after the deadline for Keeneland. So keep that in mind. There is a theme in this year's Academy Health meeting that's devoted specifically to public health and population health research. I happen to be the theme leader this year for that theme, so I really want some good abstracts coming in, and certainly some good abstracts from our public health PBRNs. We in the years past have been able to fill at least 2 or 3 sessions at the main Academy Health meeting, sessions dedicated to public health public health systems and services research. So, so give me some good abstracts to work with, and please consider submitting to the Academy Health meeting as well. Both of these meetings have the possibility of submitting panel applications as well. So if you've got an idea for organizing a panel, an entire panel or session on a related theme, you know, we're glad to help organize those kind of panel submissions as well. So if you've got an idea or want some help, shoot me an email, give us a call, and we can help do that. But we are going to, you know, this is going to span the holidays, so I want to make sure those deadlines are on your radar. Okay, so with that, the last thing that we want to talk about, and this is why we asked to kind of extend our agenda a little bit today, is to talk about some additional new funding opportunities that are coming down the pike. Before I launch into that, let me pause briefly and ask if there are any burning questions or issues that people want to thirst before we go into that conversation.
Glenn, this is Nancy from New York. We were just wondering if there was going to be a PBRN meeting this year in conjunction with the Keeneland Conference.
Yes, there absolutely will be. Thank you for asking that question, because I should have mentioned that. We will have our normal Public Health PBRN grantee meeting to be held in conjunction with the Keeneland Conference. And so we'll be sending out some information shortly about that. We do have, as we have in past years, we've got funding available to support travel for at least 2 people from each of our 12 primary networks, and we also have some funding perhaps to support some travel for some folks from our affiliate networks as well. So we will be planning a grantee meeting that will be held in conjunction with the Keeneland Conference that will start the day before the main Keeneland Conference starts. And so we'll email out to you some more information about that, and we're already beginning the planning for that meeting as well. So so yeah, definitely keep that on your radar.
Great, thanks.
Other quick questions before we launch into a discussion of some upcoming new funding opportunities? Fantastic. Well, in terms of new funding opportunities, one is I want to make sure people are aware that we do have the Quick Strike research opportunity that is open for business and open for ideas again this year, as we have in past years. We've already received, I think, at least 1 Quick Strike application, and I've talked to some other folks and some other networks. We know that some applications are in the works. But as you have ideas for Quick Strike research topics that are time-sensitive in nature, research opportunities that are time-sensitive in nature, that you can actually move forward with a modest-sized grant of about $25,000, particularly study that's likely to lead to new research down the road and to lead to timely findings that can be of interest to practice and policy. Think about submitting a quick strike application and sending us a brief proposal on your idea, because we do have that opportunity available for you. The new funding opportunity that is late breaking, and we want to make sure you're aware of, is a funding opportunity that is being offered just to the public health PBRNs, to our primary and affiliate networks in the public health PBRN program, to support junior investigators to work on a research project in conjunction with the ongoing research of a public health PBRN. And so this is a special award for junior investigators, particularly investigators from underrepresented backgrounds that are underrepresented in health and public health research. And so this is an opportunity just for our public health PBRNs. We have funding. The foundation has made available just very recently funding for us to support up to 4 up to 4 awards through this new initiative. And so what these awards will provide resources of $10,000 approximately that can go to support a junior investigator. This could be a pre-doctoral student, someone in a doctoral program approaching dissertation research, or could support a postdoctoral investigator, someone who's finished their doctoral degree, but that is within a couple years, within 3 years of finishing that doctoral degree, and is working in a postdoc or a junior faculty position. Those people would be eligible for this award. Importantly, though, they need to be partnered up with one of our public health PBRNs in a mentored research experience. And so we're looking for people people who are within one of our PBRNs who could provide mentorship to a junior investigator, pre-doc or postdoc, from an underrepresented background, who'd be interested in using this support to conduct some research that's relevant to research that's ongoing within your public health PBRN. And so this is an opportunity that's very similar to the mini grants that the PHSSR mini grants that the foundation has been supporting for a couple of years now through the University of Kentucky PHSSR Coordinating Center. And so this is an opportunity now that we'll offer just to the public health PBRNs, and again, targeted at identifying junior investigators from underrepresented backgrounds, racial and ethnic minorities, socioeconomic backgrounds that are underrepresented, et cetera, who could come and augment your research network, could augment some research that's already happening within your network, and provide an opportunity for some mentorship for this junior investigator through your PBRN network and the research that's happening there. So Ann just sent out recently some more information about this program. Let me ask Ann if there's some additional details that we want to communicate about this.
I had sent out, this is Ann Kelly, an email earlier this week with the announcement, which was also attached to the agenda for today, and the summary of research questions from the new PHSSR research agenda. And so in addition to addressing issues of health equity and health disparity in the proposed research, the investigator needs to link the research to a question in that draft research agenda. I think beyond that, I just wanted to mention that the funding actually comes from the University of Kentucky through a sub-agreement with the University of Kentucky of our RWJ funds. And so the application is to be sent not to Robert Wood Johnson electronically, but in this, we're handling the application process through an email to us here at UK at publichealthpbrn@uky.edu. So that's all in the announcement. If you have any questions as you get into it, there's contact information in the announcement, or feel free to contact us again at the publichealthpbrn@uky.edu.
Great. and unfortunately, like a lot of these RWA funding opportunities, the deadline, the turnaround time is pretty quick. The deadline for submissions, do you remember, Ann or Jay?
January 17th.
We think it's that's right, yeah. I think it's January 17th. So if you're interested in this opportunity, it's a relatively brief proposal, but we need to get a proposal from you by January 17th. And so if you have someone like this in mind, if there's a pre-doc or postdoc that you know of who would be interested in working with your PBRN, working on a topic related to health disparities or equity, social determinants, and that is from an underrepresented background, and that you would provide a good opportunity for this person to get some mentorship and to become involved in your network's research. This is a good opportunity for you, and again, it provides $10,000 of support, which is not a huge amount, but certainly enough to provide some support for a junior investigator to help them move along in their research careers, and also to help your network in building its research agenda and building enhancing the work that's happening through your network. So. Yep.
This is Ann again. One additional component is that all of the investigators who receive these $10,000 awards are required to attend the Keeneland Conference, and through the National Coordinating Center on PHSSR, we provide the travel support. So we would want those who receive this award to attend the Keeneland Conference in April again, April 17th through 19th here in Lexington, Kentucky. And they would just be beginning their award at that point, and then a year later we would want them to come and present the results of their research at the 2013 PHSSR conference.
Hopefully we'll have. We should have money to pay for their travel then, but we can't guarantee that.
Yeah.
But that's the plan.
So they could potentially get two trips to Keeneland out of this grant, in addition to getting the $10,000 of support. And of course, the big sell is the opportunity to work with one of your networks and to get some mentorship and guidance from the great colleagues that you have working in your network. So, if this looks like it's an opportunity that would fit with your network and some colleagues that you're working with, please take a look at it. Again, we've got resources to fund up to 4 of these. The turnaround is pretty tight. We need to get an application from you by the 17th of January. It's a fairly abbreviated application process that we'll be handling internally here at the University of Kentucky. So, again, hopefully it's a good opportunity for you. If you got questions, feel free to shoot us an email or give us a call, and we'd be glad to help you with that. Anything else on that front? Okay. Oh, yeah, just in terms of other funding opportunities, we did thank you for those of you who applied to the multi-network research opportunity. We received 10 applications, I believe, in response to that call last week. We are in the process of getting the review process set up and underway for that, and so we'll be in touch shortly after we've gone through the review process and have had feedback to offer on that, but we were really excited by the response and the interest here in what is a project that is in many ways going to be fleshed out as we move forward with identifying specific measures and research opportunities to carry out collaboratively. But we're very, very excited about that opportunity as well, and excited by the applications that have come in on that. So stay tuned as we move that piece forward as well. And otherwise, there continues to be some interesting funding opportunities, potentially relevant to PHSSR, that are coming out from other funders. We'll continue to profile those in the newsletter, so stay tuned to that as well for those of you who are looking for other funding opportunities to get some research projects of interest to you funded and underway, because there are some new opportunities coming out from some non-traditional sources, like the new Innovation Center at CMS that now has some funding opportunities underway, as well as the new PCORI, Patient-Centered Outcomes Research Institute, that has some interest in funding some population health related strategies. So stay tuned to our newsletter as that comes out, if you've got some interest in some of these other funding opportunities. And so let me say, any questions before we close out the call today that folks want to raise? Yeah. Well, hearing none, I think we can go ahead and adjourn. Thank you so much for participating today. Thanks for accommodating the slightly longer timeline. We had this opportunity to involve Shoshana and pick her brain a bit, so thank you for your flexibility on that. Thank you again to our colleagues in North Carolina, at UNC and the North Carolina Public Health PBRN for taking the time to share their research and progress with us. Very interesting research. I think that we can all learn a lot from, and we'll look forward to continuing to see how that project rolls along. And don't hesitate to contact us if we can be of help. And have a great holiday if we don't talk to you before then. Take care.
Thank you.